Hi, and welcome to your neurosurgery preview. I'm Mark Sowers. And as always, let's begin with anatomy. Now, of course, when people think neurosurgery, they usually think the brain, but actually a lot of neurosurgery procedures are done on areas other than the brain. So a lot of the procedures that you're going to see that you're going to get as neurosurgery procedures, a few of them might be brain surgery, the craniotomies and things like that, but a lot of those surgeries are probably going to be things like spinal surgeries and maybe even involving some of the peripheral nerves. But starting with the brain, because that's where it's interesting, we have the brain that's divided into two hemispheres. We have the right and the left hemisphere, and down the middle, separating those two hemispheres, is the longitudinal fissure. So that's a deep sort of cut or a gap between the two hemispheres of the brain. And then each hemisphere is made up of lobes. We have the frontal lobe, the parietal lobe, the occipital lobe, and the temporal lobe. Now, across the surface of the brain, we have these bulging areas and we have these little indentations. Now, the bulges are known, each bulge is known as a gyrus. So a bulgy area, the sort of rounded part, is a gyrus. And then the little indentations, we have fissures and sulci, or a singular sulcus. So a fissure or a sulcus is one of the little indentations. Now, the difference between the two, and often you'll hear them used sort of interchangeably, but there is a slight difference. The fissures tend to be bigger and deeper. So think of the longitudinal fissure that separates the two hemispheres of the brain. That's a fissure. Now, a little bit smaller than that, doesn't go quite as deep, is a sulcus, and you can see several of these sulci across the brain, and many of them are used to differentiate between one lobe and another. So we have the central sulcus, which runs down the side of the brain. That separates the frontal lobe from the parietal lobe. And we also have the lateral sulcus, which separates the temporal lobe from the frontal lobe. Down towards the back, we have the cerebellum, which is considered an old brain. Now, as we enter the skull and go towards the brain, we're going to pass through several layers. So the skin layers first, followed by the skull itself. That's the bony layer. And immediately beneath the skull, we have the dura mater. Now, the dura mater is a very tough, fibrous tissue. I think of it, kind of like fascia. I like fascia. It's dense. It's tough. Think durable. Okay, dura mater, durable. So that's that tough layer that you would have to go through as you try to access the brain. Immediately below the dura mater is the arachnoid mater. Now, arachnoid is the high-class term for spider, and they call this layer the arachnoid mater because it kind of looks like little spider webs all through this little area. So it's not a solid layer, it's all these little fibers that have large gaps between them, and in between the gaps, there's a fluid, which is the cerebral spinal fluid, and we're going to get to that in a few minutes. So this fluid flows through this sort of web-like layer here. Below that is the pia mater, which is just a very thin layer, and immediately below that is the brain itself, the neurons and the other cells that make up the brain itself. And together, these three layers are known as the meninges. So meninges is the high-class term for these three layers collectively. And you've heard that term. Think of meningitis, which is an inflammation of the layers surrounding the brain, as opposed to encephalitis, which is an inflammation of the brain tissue itself. So meningitis is an inflammation of these three layers that surround the brain, the dura mater, arachnoid mater, and pia mater. And if there's some injury or some bruising to this tissue, you can form a hematoma. Now, a hematoma is basically a large bruise. You want to think of it that way. So you can have bruising or a little bit of bleeding. That's the blood sort of gathers in these areas. Now, if the blood gathers between the skull itself and the dura mater, that's going to be an epidural hematoma. So epi meaning above or outside of the dura. So epidural hematoma is going to be between the skull and the dura. Now, a subdural hematoma is going to be below the dura. So that's going to be between the dura mater and the arachnoid mater. So that a little bit of bleeding in that area is going to be a subdural hematoma. And you can have bleeding in the arachnoid mater, that webby area as well, and that would be an arachnoid hematoma. Now, of those, one of them is much more serious, much more emergent. It is more of an emergency than the others. That is the epidural hematoma, because Most of the time, when you think of an epidural hematoma, we're talking about a skull fracture, an injury that has actually broken the skull itself, and you start to get arterial blood appearing between the skull and the dura mater. So that's going to be an epidural hematoma, and that blood is usually going to be arterial blood, which is going to be under high pressure. So that bulge, that hematoma, is going to grow and expand very quickly, putting a lot of pressure on the brain. But if we have a subdural hematoma, that's below the dura and above the arachnoid mater, in that little space there, again, very subtle difference, but there is a difference there. If we have a subdural hematoma, that's usually, not always, but usually going to be venous blood. It's going to be blood from the veins. And blood from the veins, as we learned, is under much lower pressure, much lower blood pressure than the blood from the arteries. So that hematoma formed by the venous blood, the blood from the veins, is going to grow much more slowly because it's under much less pressure than the blood from the arteries. And while both of these are bad, it is the epidural hematoma, the arterial blood that is under high pressure, that creates an emergency situation that we need to get in there and take care of very quickly. Now, coming out of the brain itself, we have the 12 cranial nerves, those nerves that originate from the base of the brain itself. And you can see the list here, and you've heard these before. And I'm going to tell you, you want to know these, you want to memorize these, you really want to understand these, because these tend to show up on tests all over the place. And I guarantee there's going to be at least one of these that's going to appear on the national boards. So get to know your cranial nerves. It's really important to know these. Now, if you have a great memory, lucky you, you can just memorize this list. But if you have a terrible memory like I do, then you have to use some sort of a mnemonic, some sort of a system in order to remember the order of these nerves. So with the mnemonic, what you do is you change each of these 12 words, but you keep the first letter, and that's what's going to remind you. So the mnemonic that I use, the sentence that I use in order to remember this order, is this. Oh, to touch and feel very good velvet, ah, heaven. You thought I was going to say something different, didn't you? But just remembering the mnemonic isn't necessarily going to help you, because it starts out with O, and you got to remember, okay, now which O is which? It gets a little confusing. So that's one of the reasons that I really like this graphic. This is a really cool graphic. Now, not only is it color-coded, it shows sensory fibers versus motor fibers in red versus blue, which I think is kind of cool. But it also shows that those cranial nerves are actually in order, meaning the nerve at the very front of the brain is number 1, the nerve just behind that is number 2, and so forth and so on down to number 12, which is at the very back of the brain. So they're in order from front to back, and remembering that is going to help you out a lot. So for example, again, I said O, okay, so which O is which? Which one's the optic one? Everybody says the optic's 1. No, it's actually number 2. So here's how you remember that, okay? The very front, the very first thing, imagine walking into a pane of glass or something like this. The very first thing that you're going to hit is your nose. So the first cranial nerve, number 1, is going to be the olfactory nerve. And then behind that, the next thing that you're going to hit is your eyes, so the optic nerve. And then the muscles behind the eye, that's going to be the ocular motor nerve, and then so forth and so on backwards throughout the brain. So the facial nerves, number 7, are going to come just slightly before the vestibular cochlear nerve for the ears, number 8, because the face is just a little bit before the ears. Now, this isn't a perfect system, especially the A's like to jump ahead a little bit, the 2 nerves that start with the letter A, but most of them sort of follow this order from front of the face all the way to the back of the skull. But if you're a more visual person, I really like this image. I think it's kind of cool. All right. The numbers, this whole guy's face is made up of numbers, and those numbers represent the cranial nerves. Look at this. You have a 7 on each side of the face, making up the face itself. What's the facial nerve? It's number 7. That's kind of cool. What's the vestibular cochlear nerve for the ears? Number 8. What's the nerve that runs the sternocleidomastoid muscles in the neck? It's number 11. So you can look at this graphic and see which areas are either controlled or sensed by which cranial nerves. Now, as we get deeper and deeper into the brain, we get into older and older sections of the brain. Again, the cerebellum in the back, that's an older section. And older still, we have the thalamus at the very top of the brainstem, and most people consider the brainstem to be three elements, which is the midbrain, the pons, and the medulla oblongata. So the midbrain, the pons, and the medulla oblongata make up the three sections of the brainstem, which then goes down into the spinal cord. An important part of the brain is the pituitary gland, which is actually the endpoint for a bunch of nerves. They come in there, and what they do is they generate hormones that help control the body. So the pituitary gland really is a very important gland because it sort of controls many of the other functions, especially hormone functions within the body. And the pituitary gland sits in its own little chamber of the sphenoid bone known as the sella turcica. And when you have a term, something like sella turcica, you can pretty much guarantee that it's going to appear on a test somewhere. So the sella turcica is the little hole that the pituitary gland sits in. And it happens to be sized exactly the right size to hold that pituitary gland. Now, how does that happen? I mean, I think that's kind of cool, but how does it know that it's the exact right size to hold that pituitary gland? Well, that actually happens to go back to embryology, which is also a very cool topic I'm not going to get into here. But basically what happens is the pituitary gland off of the brain forms first as the embryo develops. So the pituitary gland forms first, and then the sphenoid bone hardens around that already existing pituitary gland. So that's why the pituitary gland is a perfect fit inside the sella turcica. Now, bathing the brain, we have a fluid known as the cerebral spinal fluid. And this fluid originates in some of the ventricles of the brain. Now, what are ventricles? Okay, think of the ventricle of the heart. It's sort of a gap, a hole in the heart that fluid gathers in before it's, squeezed out. But that hole, that chamber that holds fluid is known as a ventricle. So think of the same thing in the brain. We have several ventricles in the brain that hold fluid. In this case, we're talking about the cerebral spinal fluid. Now, the cerebral spinal fluid itself originates in a number of cells sort of gathered around these ventricles known as the choroid plexus, and I should have it shown here in red. So the choroid plexus is these special cells, this special tissue that sort of releases cerebral spinal fluid into the ventricles, which then flows out and around the brain. Another one of those terms that's likely to appear on a test somewhere is the aqueduct of Sylvius, or as shown here, the Sylvius aqueduct. This is going to be a little canal that leads between the third and the fourth ventricle that a lot of that cerebral spinal fluid, or CSF, flows through. So the spinal cord extends down through the spine itself, and the spine is made up of a total of 5 major sections. We have the cervical section, the thoracic section, the lumbar section, and then we have the sacrum and the coccyx down at the bottom. And there's a couple of things that differentiate between those top 3 sections, cervical, thoracic, and lumbar sections of the spine. The first difference is that the cervical area, if you're looking at the back of the spine, tends to be a little bit of concave. It sort of curves inward. The thoracic area is convex, curves outward, and then the lumbar area, again concave, curves inward. And also we have 12 main ribs, and those ribs extend from the thoracic vertebrae, from those 12 thoracic vertebrae. So how many vertebrae do we have? Well, at the cervical area, we have 7 cervical vertebrae. Thoracic, as I mentioned, we have 12 thoracic vertebrae. And then in the lumbar area, we have 5 lumbar vertebrae. So how do I remember these numbers? Well, think about it this way. I have breakfast at 7 o'clock. I have lunch at noon, 12 o'clock, and I have dinner at 5 o'clock. Yeah, I'm old. I eat dinner at 5 o'clock. Okay, just go with it. So 7 o'clock, 12 o'clock, and 5 o'clock when you eat your 3 meals, or when I eat my 3 meals, all right? And those are the numbers of vertebrae in each of these sections of the spine. Down to the sacrum. The sacrum was initially made up of 5 separate bones that during development have fused together. So there are S1 through S5. And then the coccyx is made up of 4 bones that eventually fuse together. So we have CO1, 2, 3, and 4. So out of all those, we have a total of 33 different vertebrae, or at least vertebrae sections, making up the spine. And of course, the shape of each of the vertebrae in the different sections are a little bit different. Notice the cervical vertebrae are a little bit smaller, the lumbar being a little bit larger because they're holding up more weight, obviously. And each vertebrae, each bone itself, has different sections that you should be aware of. So the main section, the largest section, is the body. So the body is the largest section of the vertebrae. And just behind the body, we have this hole, this gap, which is known as the vertebral foramen. Now, foramen means hole. So we have a hole in the vertebrae, and through the hole goes the spinal cord. That's where the spinal cord goes. So the vertebrae sort of surrounds and protects the spinal cord in this area. The circular part, the part that goes behind the spinal cord, is known as the lamina. That's the part that goes around in a circle behind the vertebral foramen. Sort of extending from the sides, we have the transverse process. Now, a process is an extension of bone, a piece of bone that sort of sticks out in one direction. And in this case, we have two of these. We have a transverse process, transverse meaning sort of to the side or across. And then we have a spinous process that sort of comes out the back. And actually, in humans, spinous process doesn't necessarily do a whole lot. So you're going to see them being removed fairly often, and that's not going to cause a whole lot of problems. So let's go over a few neurosurgery terms before we get to the procedures themselves. In order to stabilize the skull during brain surgery, we don't want that to move at all, right? Because it's very delicate work. So we want to make sure it's really fixed well in place. We use something called a skull clamp or a Mayfield. So the Mayfield is a skull clamp that holds that skull in place and keeps it from moving at all. Kind of a nasty looking device, but believe me, it's really important because you don't want any motion at all. In the lumbar section of the spine, we have a bundle of nerves called the cauda equina. Now, believe it or not, the spinal cord doesn't go all the way down to the bottom of the spine. It stops at about L1 in most people. And that's because the spinal cord itself actually stops growing before the rest of the spine does. So the spinal cord will get this long, but then the spine itself keeps growing and keeps growing and keeps growing. So the spinal cord is actually stopped. But as the spine keeps growing, it actually pulls the nerves that extend out through the vertebrae, sort of pulls them back and up towards the spinal cord itself. So that's why you have this sort of bundle of nerves extending down through the lumbar region of the spine. And again, it's known as the cauda equina. Now, cauda equina, there's a high-class term. You know it's going to appear somewhere. So let's figure out what it means. So cauda means tail, and equina means horse. So equine, equina, all right? So that's where it comes from. It comes from looking like a horse's tail. And in fact, that's what it looks like. This bundle of nerves extending down kind of looks like a horse tail. So that's why it's known as the cauda equina, Latin for horse tail. Now, sometimes we need to access the area around the spinal cord for a variety of reasons. And each of these different reasons and each of these different techniques comes with a different name. So let's clarify the differences between epidural, spinal block, and lumbar puncture, which is a spinal tap. So an epidural, in this case, remember we had the epidural hematoma, so that's going to be above or outside of the dura mater. Now the dura mater extends all the way down the spinal cord as well and surrounds the spinal cord. So the epidural is outside of that dural layer. So the epidural space in the spinal column is between the bone and the dura mater surrounding the spinal cord. And this little space is mostly kind of a fatty tissue in there, sort of protects it a little bit. So that's outside of that dural space. So when we're doing an epidural, usually to provide a little bit of anesthesia, provide a little bit of pain control, what we're going to do is we're going to insert the needle into this epidural space outside of the dura, and then insert a little catheter into this space where we're going to slowly trickle in a little bit of anesthetic agent that's going to help to numb. Now, because we're outside of that dural space and we put this anesthetic in there, it's going to take it a little while to make its way in to the nerves itself because it's outside, right? So it's going to take a little while. So an epidural takes maybe 10 to 30 minutes or so to really sort of take effect. That's because it has to make its way through the dura mater and into the nerves themselves. But the advantage of an epidural is that the catheter can stay in there. We're going to take the needle out, but we're going to leave the catheter, the soft catheter, in there, which means we can continuously pump just a little bit of this anesthetic into the area and keep that pain blocked for a long period of time. Now that's different from a spinal block. Now a spinal block, we're going to take our needle, go through the epidural space, through the dura itself, and when the doctor does this, or the anesthesiologist does this, they're actually going to feel for a little pop. There's going to be a little pop as they push through that dura because it's kind of tough, right? It's durable. So they're going to feel this little pop, this little give in the resistance as they insert it. They're going to go through into the subarachnoid space where all that cerebral spinal fluid is, the CSF, that's flowing through and around the spinal column. So in this case, we're going to do a spinal block. We're going to inject that anesthetic into the CSF right next to the spinal cord itself, or right next to the cauda equina, which means it's going to take effect almost instantly. It's going to be very fast acting, but you don't want to leave a catheter, you don't want to leave a needle in that space because the nerves are right there. We don't want to damage it. So we're going to have to go in, inject, and take it out very quickly, not leaving it in there. So a spinal block is very fast acting, but it's not going to last a long time because we had to take it out. And once that sort of goes away, that anesthetic goes away, that pain is going to come back. And a lumbar puncture or spinal tap is slightly different than a spinal block in that we're not injecting anesthetic into the CSF around the spinal cord, but we're actually going to withdraw some of the CSF in order to send it to pathology, to examine it, to find out what's going on. So a spinal block, we're putting anesthetic into that subarachnoid space, that CSF, the cerebral spinal fluid around the spine. And a lumbar puncture or spinal tap, we're going to be withdrawing some of that CSF. So they are slightly different. It's very similar the way it's done, but it's slightly different because one's putting anesthetic in and one's pulling the CSF out. So let's take a look at some of the surgeries that you're going to see in your neurosurgery clinicals. The craniotomy, that's the one everybody likes to get. It's kind of cool to watch. In this case, we're actually going to remove the skin from the skull, cut through the skull itself, remove the skull, go through the dura, that tough fibrous tissue, and then expose the brain itself. So a craniotomy, otomy-O, we're going to make an opening or a hole into the cranium, the skull itself, to access the tissues below. One of the reasons we might do a craniotomy is to repair an aneurysm. Now, an aneurysm is a bulging of an artery. Usually, this occurs at a bifurcation, at a point where the artery sort of forks or splits into two different arteries. So an aneurysm, this little bulging that can occur there, if that bulging gets worse and worse, that artery wall is going to thin out and thin out. And if it breaks, now you've got a significant arterial bleed in the brain, and that's going to cause a lot of problems. So if we can catch that aneurysm before it breaks, and we can sort of clip it off and pinch it off. What we're going to do is put a little aneurysm clip right across it, and that's going to pinch it off, seal it off, and that way, if that aneurysm ever does break, it's going to be sealed off from the rest of the artery, and it's not going to bleed heavily into the brain, and that's going to be a good thing. Now, sometimes the skull bones won't form in the nice round shape that we're kind of used to seeing, and in this case, we can go in and do a cranioplasty and change the shape of the skull itself. Here we're going to pull the skin away, and because the skin bleeds a lot, we're going to use Rainy clips to clip all the way around the skin itself to really seal off all the blood vessels in the skin surrounding the skull. We can remove any of the damaged or poorly shaped skull, and then we can put a plate or a cap over that and sort of screw it into place to provide the protection that the skull otherwise would. Craniosynostosis repair is a procedure that we might perform on children. Now, in this case, we have, of course, the different bones of the skull that come together at sutures, these little joints where the bones come together. They're not flexible joints, they're just the point where the bones come together. But as the child's growing, as the skull is growing, it's at these joints where the bones continue to grow and grow. So these bones, especially in young children, are not fused at these joints yet because the bones continue to have to grow and grow and grow. Well, what can happen is sometimes these bones can fuse a little earlier than they should, so the brain inside continues to grow, but once that joint's fused, the bone can't grow anymore. It can't spread apart anymore. So that's going to put a lot of pressure on the growing brain, and we have to go in there and sort of help that out. So what we do is we go in there and separate the skull bones. Instead of being fused together, we break them apart or pull them apart, separate them, so that we create a gap. So at this point, once we've fixed the bones where we want them to be with this gap in place, the patient's then going to end up wearing a helmet for probably a while as the bones eventually grow into that space and eventually cover over and finally do fuse up at the right time. If there's a problem, let's say a tumor, an aneurysm somewhere deep in the brain, and we have to find our way there very, very precisely, we can use some stereotactic measures to help us out. Now, again, we had that Mayfield skull clamp that held the brain and the head nice and steady, but we can also use sort of a GPS to find out exactly where we're going to take imagery before surgery to map out exactly what's going on there. And then we can place fiducial markers, and these are little devices that we're going to place around the skull that are going to mark certain locations in 3D space that the sensors in the room will then pick up, and even if we do move a little bit, the skull moves a little bit, we're still going to know exactly where we have to go with this very fine control to find the tumor or whatever else it is we're trying to fix in there, find that very precisely using a stereotactic or, kind of like a brain GPS system. A ventriculoperitoneal shunt. There's a big word. Let's figure out what's going on here. Okay, so we have ventriculo. So we're talking about ventricles, probably not the heart because this is neurosurgery. So these are going to be the ventricles in the brain. Or remember those little chambers that are full of cerebral spinal fluid, CSF, and peritoneal. Well, the peritoneum, that's way down in the abdomen. What's going on here? Well, what's going on is the patient has something known as hydroencephaly. They have water on the brain or too much CSF that's being produced and is not draining properly. So the pressure inside those ventricles, the pressure of that CSF is building up and building up. And what we want to do is we want to be able to relieve that pressure and let that CSF drain away. So we're going to add a shunt, a tube that's going to run from the ventricles in the brain and run it all the way down through the neck, through the chest, and into the abdomen, into the peritoneum, where we're just going to put the end of that shunt and let that CSF fluid sort of drain away into the abdomen, where it'll eventually be reabsorbed by the body. So this way, if the pressure does build up even a little bit in those ventricles, it's going to force the fluid through this shunt and out into the peritoneum, not putting pressure on the brain itself. But sometimes if we need to see what's going on in these ventricles, these little fluid-filled sacs deep inside the brain, we can do a ventriculoscopy. So scopy, we're going to be looking in, putting a little camera, a little tube in there to look through this tube to see what's going on. And usually we're going to do a craniotomy, make a little hole, probably through the longitudinal fissure to get down into the ventricles and take a look around and see what's going on. So that's a ventriculoscopy. And one of the things that we can see during a ventriculoscopy is the very top of the pituitary gland. So we're getting that deep into the brain, looking around in the ventricle, looking around the top of the pituitary gland and other structures in that area to see if there are any problems going on there. But sometimes we can tell that there's a problem even without doing a ventriculoscopy. Sometimes just the imagery, see MRI, can tell us that there might be a problem, say, with the pituitary gland. And if there is, we're going to have to go in and say, remove the pituitary gland if we have a little tumor or growth on that, because it's sitting in that sella turcica, which was wrapped around exactly the right size for the pituitary itself. But if we have a little tumor growing on that, well, now it's stuck. It's going to be putting a lot of pressure. It has nowhere to grow to, and that's going to cause a lot of problems. So we're going to have to go in there, remove that tumor and probably with the whole pituitary gland itself. And the way we're going to access that is instead of going through the longitudinal fissure, and I guess we could do that, but most of the time it's easier to go up through the nose and do a transphenoidal hypophysectomy. Now let's break that one down. Okay, transphenoidal, we're talking about the sphenoid bone, which is where the sella turcica is, where the pituitary sits in the sphenoid bone. So we're going transphenoidal, we're going across or through the sphenoid bone. And the hypophysectomy refers to the high-class term for the pituitary, which is the hypophysis. So hypophysis is the high-class term for pituitary. So a hypophysectomy is going to be the removal of the hypophysis or the pituitary gland. Now, a lot of the procedures that you're going to see, especially now that you're just starting out, are going to involve the spine rather than the brain. Yeah, you're going to see some brain maybe, but most of the time you're going to be working on the spine or other peripheral nerves. So let's take a look at some of these. One of the problems that can happen with many patients is that they can have something called lumbar stenosis. Now, stenosis means a narrowing or a stricture, a narrowing of a gap that something's supposed to flow through. So in this case, we have the nerves that flow through the lumbar portion of the spine. But if that area, that gap gets narrower and narrower, let's say there's some problem with the bone and maybe there's a little destruction in there and there's some tissue growth where we don't want it, it gets narrow, it starts to pinch on those nerves and that can cause a whole lot of pain. So with lumbar stenosis, we're going to go in and relieve that pressure by doing a procedure known as a lumbar laminectomy. Now, a laminectomy, ectomy means removal, removing the lamina. Now, remember, the lamina is that curved piece of bone that goes around the back of the spinal cord. So that's curved piece of bone around the vertebral foramen. That's the lamina. And in order to remove the lamina, we usually end up taking the spinal process as well, again, because we don't really need them, at least in humans, we don't really use them. So we'll take the spinal process and the lamina itself, that back part of the vertebrae, and remove that completely, releasing the pressure on those nerves in there. But sometimes there's a problem with the disc, that soft sort of piece of cartilage that separates the two vertebrae from each other and adds a little cushioning. Sometimes there can be a problem with that disc, or maybe the spinal vertebrae are offset a little bit, known as subluxation. So if a vertebrae is not lined up with the one below it, that's going to be a subluxation. So we can go in and fuse those two vertebrae together, removing the disc entirely and fusing those two vertebrae together, just as we would, say, with an arthrodesis, where we're fusing other joints together. So in this case, we're going to fuse the vertebrae together, and this is often done in a procedure known as a transforaminal lumbar interbody fusion, or a TLIF is what it's often abbreviated as. And during one of these procedures, we're going to go around the spinal cord, remove the tissue of the disc itself, that cartilage that separates the two vertebrae, remove that tissue, and then replace it with bone graft or other material that's going to help fuse those two pieces of bone together, those two vertebrae together. And to help hold these vertebrae together, we're going to have to drill through the vertebrae, put some screws in, and then run a brace on each side of the spine and connect it to these screws that's going to help hold those two vertebrae together. And one thing that you'll find is that different doctors have different ways that they like to do a procedure like this. So the TLIF is sort of one of the original ways of doing it. And you put the screws in at sort of a little bit of an angle. But there are other newer versions that you're going to see more and more of now as doctors learn these newer approaches. There's the PLIF, where the screws come in straight through a tinier hole, so it's sort of minimally invasive. You can have an L-lift, where it sort of comes in laterally from the side. You can do an O-lift or even A-lift, an anterior fusion. So you're approaching the spine from the anterior or the front side. But all of these are basically doing the same thing. You're removing the disc tissue, replacing it with some graft or other hardware, and you're going to fuse those two vertebrae together with some more hardware. A common source of pain for many patients is a herniated disc. Now, the disc, again, being that cartilage area between the two vertebrae, between the two vertebral bodies, and it provides that cushioning. And that cartilage is made up of two different layers. You have the outer layer, the very tough layer. This is known as the annulus fibrosus. So fibrous, it's real tough, it's strong tissue, it's strong cartilage in there. And then you have a sort of a softer layer in the middle. This is the nucleus pulposus. So nucleus, think sort of the center of the disc, and pulposus sounds kind of soft. So the nucleus pulposus, that's the softer center of the disc, and the annulus fibrosus, that's the stronger, tougher outside portion of the disc. Now, if those fibers in that disc sort of break down a little bit, sometimes parts of that disc, because it's bearing so much of the body weight, especially in the lumbar section of the spine, and sometimes that disc will bulge out into a space where it's not supposed to be. And of course, with the spinal column, there are a lot of nerves around, so it's very likely that it's going to press against or pinch a nerve and cause a lot of pain. So one minimally invasive procedure is known as a microdiscectomy. In this case, we're not creating a large incision, we're making a tiny little incision and sort of working our way down through this tube to get just around the spinal cord, find the disc itself, and very gently and carefully bite away at the disc, taking those little pieces that are protruding where they're not supposed to be away, and then we can seal that back up, relieving the pressure on that nerve. Many of these procedures, the lumbar laminectomy all the way through the microdiscectomy, are done on patients when they're in the prone position, they're face down, but they're placed on something known as a Wilson frame, which is a special kind of operating table or operating bed, which has these two little arched pads area. And what that does is sort of arches the lumbar spine upward, separating the back of those discs, the back of those vertebrae a little bit so that the doctor can get in between those intervertebral spaces a little bit more easily. That's a Wilson frame. But surgeons have found that in some cases they have better success if they approach the vertebrae from the front rather than the back. And that means you have to go through a lot more tissue to get there, but it can lead to a more successful surgery. And that's where we have the anterior cervical discectomy and fusion, or ACDF. So in this case, we're doing anterior. We're approaching that vertebrae from the anterior, the front side, cervical. So we're in the neck region, and we're going to do a discectomy and a fusion. So we're going to take the disc out between the two vertebrae, and then we're going to fuse those vertebrae together. But we're doing it all from the front approach. And this is also going to involve placing some bone graft in where that disc used to be, and then using a plate or some other hardware in order to fuse those vertebrae together. Similar to the lumbar laminectomy, if we have to decompress or relieve the pressure on the spinal cord in the cervical area, in the neck area, we can go in and do a posterior cervical decompression. So in this case, we're going to go in and remove, again, that spinous process and some of the lamina, which is that part of the vertebrae that circles around the back of the spinal cord. So here you can see some of the hardware that would be used in a case like this, and the number of vertebrae affected can change dramatically from patient to patient. Sometimes it's only 2 vertebrae that you're fusing together, and sometimes it could be 4 or 5 vertebrae that you're going to fuse together, all using one long rod running from vertebrae to vertebrae to vertebrae. Getting to the thoracic vertebrae from the front of those vertebrae can be a little bit of a challenge, but it's still doable using an anterior thoracic decompression. Now in this case, instead of coming straight from the front, we're actually coming through the side a little bit because, you got your heart and your lungs right in the front. So we're going to come in through the ribs themselves, behind the heart and the lungs, and approach the front of the vertebrae that way in an anterior thoracic decompression. A rhizotomy involves creating a hole or a gap, essentially cutting a nerve root. Now, nerve roots run from the spinal column out into the extended peripheral tissue, and that can be the source of a lot of pain. And sometimes if that pain can't be controlled by medicines and other therapies, sometimes the doctor will go in and actually do a rhizotomy, in which case they'll cut the nerve root itself. Usually they'll go in and ablate it. They'll burn that tissue in some way. They'll burn that nerve root and do a rhizotomy, and that's going to alleviate the pain that patient may feel distally from that nerve root. Now, in the peripheral nervous system, sometimes patients can have problems with their elbow, with the funny bone. Now, the high-class term for this is the ulnar nerve, which runs up to the pinky and the ring finger. And sometimes if you press on that funny bone, you can cause tingling in this area. Now, why do they call it the funny bone? Because it's humorous. Okay, so anyway, what they're going to do is they're going to move this ulnar nerve into a different location so it doesn't keep getting pressed on in this area. So in this procedure, the ulnar nerve runs through a gap called the cubital tunnel, just like the carpal tunnel that you have in your wrist. You have a cubital tunnel in your elbow, and the ulnar nerve runs through that. And if it continues to get caught or pinched in that area, you can actually take that ulnar nerve and move it out of that. So you're going to transpose or transposition of this ulnar nerve, moving it to a different location where it's not going to be pinched, where it's not going to cause that tingling sensation. So you can see here where the nerves run through these tendons in the elbow. So what we're going to do is we're actually going to cut through those tendons, move the nerve to a different location, and then resuture those tendons together. That's a cubital tunnel repair. So thank you for watching these previews of the different surgical specialties. I hope it has helped. Good luck on your national boards.